Dr. Ruchi Verma, and I'm a practicing senior consultant in the city of New Delhi. I did my MBBS from Motilal Nehru Medical College, Allahabad, and thereafter my DNB from Delhi itself. I have been practicing with various corporate hospitals like Apollo, Max Healthcare. I am still presently with Max Healthcare as a senior consultant internal medicine. I also work for organizations like State Bank of India, and I have a vast experience of more than 23 years. We are doing a lot of DNB teaching in our hospital, in Max Hospital, Saket. We are also, I'm also a teaching faculty of many other courses that Max Hospital runs, like, for example, the public health management programs and other allied courses. So today I would just be discussing about an interesting topic, and that is uncontrolled hypertension. Now, this is something which we all as physicians are encountering day to day in our patients, and we know the burden of the disease, especially the numbers of uncontrolled hypertensive patients, which is increasingly going up every day. So, in fact, there's a lot beyond the numbers, and that is the devastating impact of uncontrolled hypertension. And I will also be talking about the role of cilnidipine and telmisartan combination as far as management of uncontrolled hypertension and the complication prevention is concerned. So, hypertension is a common condition, but we know that uncontrolled hypertension leads to very severe and life-threatening complications. According to the Global Burden of Disease study, hypertension remains the leading risk factor for cardiovascular mortality worldwide, and awareness and proper management are the key to preventing organ damage and improving patient outcomes. So, as I was talking about the severe life-threatening complications that this uncontrolled hypertension can lead to, so mainly they are vision loss, heart attack, stroke, heart failure, kidney disease, and sexual dysfunction. In most of our patients, we encounter these complications. So I'll just go shortly one by one. So when we talk about cardiovascular complications, hypertension is the number one risk factor for cardiovascular disease. We all know that. And then as far as cardiovascular complications are concerned, it could be a left ventricular hypertrophy or a coronary artery disease or a heart failure. So persistent high blood pressure and uncontrolled hypertension would lead to probably all of these. So chronic pressure overload actually leads to myocardial fibrosis and diastolic dysfunction, and hence causing left ventricular hypertrophy. Hypertension also accelerates the atherosclerosis, increasing the risk of myocardial infarction and hence leading to coronary artery disease. Again, persistent high blood pressure contributes to systolic and diastolic heart failure, and hence we have increasing incidence of heart failure in our uncontrolled hypertensive patients. The second complication, and again a very common complication, is the stroke, which is a silent threat to the brain. So hypertension accounts for 54% of all the strokes globally. There's a lot of pathophysiology involved and evidence involved. Details I won't go into, but then when we are talking about stroke, it could be an ischemic stroke or a hemorrhagic stroke or a vascular dementia. So chronic hypertension damages the small cerebral vessels and increasing the risk of thrombotic events, eventually causing ischemic stroke. Elevated blood pressure also weakens the vessel walls, leading to rupture and brain hemorrhage, and hence causing hemorrhagic stroke. And then, of course, the chronic hypertension damages the cerebral microvasculature, resulting in the cognitive decline or the vascular dementia. Yet another very important complication is the kidney failure, which is the silent victim of uncontrolled hypertension. So hypertension again is the second largest cause of end-stage renal disease. We know that is after diabetes. And when we talk about chronic kidney disease, sustained hypertension, it induces the glomerular hyperfiltration and fibrosis, leading to chronic kidney disease, and the progressive nephron loss, leading to dialysis dependence in patients, causing end-stage renal disease. Again, we know that proteinuria, and nowadays we do, of course, UACR, that is urine albumin creatinine ratio. That's a marker of hypertensive renal damage that can predict the cardiovascular risk. Another very important complication is the retinal damage, that is the hidden, again, the eye, which is the hidden danger. So hypertension is associated with 20% increased risk of visual impairment. So when we talk about hypertensive retinopathy, um, so chronic high blood pressure leads to vascular narrowing and hemorrhages, and hence ultimately leading to hypertensive retinopathy, and a reduced blood supply to the optic nerve, leading to eventually vision loss, causes the optic neuropathy. So these are the hidden dangers which the eye as an organ can encounter when we are talking about uncontrolled hypertension. Another one, very, I would say, sudden killer and a complication of uncontrolled hypertension could be an aortic aneurysm and dissection. So again, as we know that hypertension is the strongest modifiable risk factor for aortic aneurysm and dissection. Hence, it's very important to control blood pressure. So, when we talk about aortic aneurysm, the chronic high blood pressure leads to a medial degeneration of the aorta and eventually causing the aortic aneurysm. Also, the acute hypertension can cause an intimal tear, leading to life-threatening complications like aortic dissection. So, these are, in short, all the complications that we deal with in our day-to-day practice when we are dealing with patients of uncontrolled hypertension, and hence it is very imperative to control blood pressure effectively and monitor also the blood pressure control in all our hypertensive patients. So, coming to the topic of today's talk, that is the cilnidipine and telmisartan combination and its role in prevention of all these complications. So we know that cilnidipine actually is it. We all know about cilnidipine and we know about telmisartan. One is an ARB, one is a calcium channel blocker, and cilnidipine is vasoselective. It has weak direct dromotropic effect and a strong vasodepressor effect and an arrhythmia inhibiting effect. So, it provides a dual L-N type blocking action, offering vasodilation, reduced sympathetic nerve activity, suppression of the neurohumoral mechanisms like RAS inhibition and sympathetic nervous system inhibition, and comprehensive cardiovascular protection beyond the blood pressure regulation. So, it also has some clinical benefits, the cilnidipine as a molecule, in terms of cardioprotection by reducing the heart rate and infarct size and the arrhythmias and improving the left ventricular function. So we know that it is an L and it blocks the L type as well as the N type of calcium channels. So L type are responsible, they are present in the smooth muscle cells of the peripheral arteries and hence cause vasodilation, and N type are present in the nervous cells or the brain cells. Then so that is why it causes a reduced sympathetic nerve activity and suppression of the neurohumoral mechanism. Now, talking about telmisartan, well, it reduces the blood pressure by blocking the AT1 receptors, leading to increased plasma renin and angiotensin II. It also reduces the left ventricular mass and has beneficial hemodynamic effects in the heart failure patients. It improves vascular compliance and reduces the arterial stiffness. So, this again, we know that as per guidelines, whenever we are talking about double digit control, we are always talking about a dual therapy to control such patients. So, the rationale for this combination therapy is that cilnidipine and telmisartan not only reduces the blood pressure but also offers cardioprotective effects. It attenuates the high blood glucose levels and provides the vasoprotective effects. The combination therapy lowers the blood pressure without causing reflex tachycardia, induces cardioprotective effects by increasing the expression of endothelial nitric oxide synthase, and provides vasoprotective benefits by inhibiting the DNA synthesis in the cuff-induced vascular injury cells. Also, according to recent survey results, the combination of cilnidipine telmisartan is the preferred treatment option in diabetic patients, especially who have hypertension, in our routine clinical practice. So there are several studies which have indicated the combination of telmisartan and a calcium channel blocker like cilnidipine, which significantly improves the blood pressure control, also lowers the urinary albumin excretion in hypertensive patients with diabetes. So all guidelines recommend the use of an ARB or a ACE inhibitor and a calcium channel blocker as a first line treatment for patients who suffer from hypertension, as well as especially those who are diabetic. And again, various societies like the European Society of Cardiology, the European Society of Hypertension, RSSDI, and the National Consensus Statement also suggest this dual combination, the use of calcium channel blocker, especially the newer agents like cilnidipine, in combination with the angiotensin receptor blockers, that is ARBs, such as telmisartan, which will ultimately lead to superior blood pressure control, target organ protection, also enhance the cardiovascular and kidney protection in patients who have diabetes and hypertension. And most international guidelines also recommend the combination therapies to be initiated in the hypertensive patient. So, telmisartan and cilnidipine is a very good choice of combination therapy in patients with essential hypertension as well as patients who have diabetes and hypertension. So, again, I would like to highlight here that when we talk about hypertension in elderly diabetic patients, sometimes we use the diuretics as the first line, especially in cases of resistant hypertension also and elderly patients. But then when we are talking about in patients in general who are not very elderly and who don't have resistant hypertension, then a combination of ARB or ACE inhibitor along with calcium channel blocker, I think works best for all our patients. We have a lot of clinical and preclinical studies to support this. So, most of the studies have been conducted in Japan and Korea as regards cilnidipine. So, one such study, I think it was conducted in 2007 in Japan as regards cilnidipine and telmisartan improving the vascular damage in hypertensive patients. It compared the long-term effects of cilnidipine and telmisartan in hypertensive patients on markers for vascular complications. And this study actually had shown that cilnidipine and telmisartan significantly reduced the clinic blood pressure, the 24 hours blood pressure control, the daytime blood pressure, nighttime blood pressure, as well as ambulatory systolic diastolic blood pressure over a period of 12 months with similar reduction in both the groups, that is the cilnidipine group and the telmisartan group. Also, telmisartan likely enhanced the lipid metabolism and cilnidipine reduced the aldosterone levels. Hence, this study highlighted their distinct vascular benefits also. So, it actually this analysis could not really identify the definitive causal relationship to suggest the mechanism which was responsible for improvement in the intermedial thickness in patients on cilnidipine. But yes, it did prove that uh, this telmisartan and cilnidipine individually definitely controlled the blood pressure very well, and also they had multiple other benefits like enhanced lipid metabolism and reduction of aldosterone levels. So they had unique properties actually for inhibiting the vascular complications. Then there was another preclinical study which was done on rats. Again, it was a Korean study. So it explored whether the combination therapy using cilnidipine and telmisartan could effectively regulate hypertension, myocardial ischemia, again neo-intima hyperplasia, and high blood glucose levels. So it was seen that this combination therapy, especially the high dose, showed a very superior blood pressure lowering effect. The combination therapy also significantly increased the, it decreased the oxidative stress, and it had enhanced cardioprotective effect, and it also reduced the neo-intima formation. So again, this was a preclinical study. And yet another clinical observation study which was recently published. This was again in Japan. It was an observational study conducted in Japan which examined the effects of adding cilnidipine to patients who were already on a ARB. This was a large study, about 2,920 patients were enrolled in this study, and a combination of cilnidipine with ARB was shown to effectively control the blood pressure and lower the elevated heart rate without any significant adverse event. So, in this study, the blood pressure levels at baseline, at 4 weeks, at 8 weeks, at 12 weeks of the starting the combination therapy were monitored, and there was a significant reduction in both the systolic blood pressure as well as diastolic blood pressure by the end of 12 weeks. It was seen in the study, and hence it was proved that this combination had a double digit reduction in blood pressure. So again, this was a Japanese study. So a lot of research studies done in Japan and Korea and even in India as regards the combination as well as individually as regards telmisartan and cilnidipine. So as far as prevention and management is concerned, I would just like to end by saying that early intervention with antihypertensive therapy is extremely crucial to reducing mortality in all our patients who suffer from hypertension. Telmisartan and cilnidipine has a dual benefit approach. Telmisartan provides superior blood pressure control as well as cardiovascular protection. Cilnidipine is a very unique calcium channel blocker that reduces the sympathetic overactivity and also protects against proteinuria. So the combination therapy actually shows greater efficacy than monotherapy in reducing the end organ damage. And thank you. Thank you very much for listening to me.